Good afternoon. I'm Patty Johnson, coordinator of the Southeastern Council of Foundations EngAGEment Initiative. This afternoon we're delighted to present our program, Home-Based Primary Care for Older Adults, which is sponsored by the Jessie Parker Williams Foundation. The presenters include Mary Judson of the Jessie Parker Williams Foundation, Dr. Edward Espinozo, Medical Director of the House Call Program, and Dorothy Davis, Executive Director of Long-Term Care. Both Dr. Espinozo and Ms. Davis are with the Visiting Nurse Hospice Atlanta. Mary, I'm going to turn this program over to you to get us started.
Well, thank you, Patty. Jessie Parker Williams Foundation is located in Atlanta and focuses grant making on health care services for women and children with a particular interest in older adults. We've had a long relationship with Visiting Nurse Hospice Atlanta. The organization is the leading nonprofit in Atlanta providing hospice and home health care. We've supported the House Call program since its inception because we feel it represents an economically efficient and patient-centered way to help keep older adults living in their homes safely and reducing ER visits and rehospitalizations. I have the pleasure of introducing Dr. Edward Espinoza and Dorothy Davis, who I have gotten to know since we've been involved with Visiting Nurse. Dr. Espinoza serves as both the medical director and the first physician to join the House Call program. In addition to his role at House Call, he is a board-certified internal medicine physician, member of the American College of Physicians, and on staff at both Piedmont and Northside hospitals. He is one of those rare breeds who is a native Atlantan and received his bachelor's here at University of Georgia, Master of Public Health at Tulane, and attended medical school at the New York College of Osteopathic Medicine. Dorothy Davis is one of the leading experts in our community and home and community-based care for seniors and the disabled. Her role as Executive Director for the Long-Term Care at Home Division of Visiting Nurse Hospice Atlanta makes her responsibilities include 2 Medicaid waiver programs, the House Call Primary Care Practice, Alzheimer's Respite Care, and case management for 2 county-based systems. Dorothy received her master's degree in developmental psychology from Vanderbilt University. I also wanted to thank Lisa Robinson, who's Vice President of Advancement at Visiting Nurse Hospice Atlanta, and her staff for helping us recruit Dorothy and Dr. Espinoza to present and also help handle the logistics of getting their presentation together. Without further ado, I turn it over to Dr. Espinoza and Dorothy to give us this presentation.
Well, thank you very much. This is Dorothy. I'm going to start us off, and Dr. Espinoza, he and I are going to go throughout and speak to different things. First of all, I want to thank the Southeastern Council of Foundations for hosting this. We are very excited about this program. We've been around since 2010, so it's still very new for us. It certainly has fit into our mission as a way we serve folks in their homes and in the community. And so we're going to take you through just sort of the whole, why it makes sense to us, how we operate, the delivery model, and what actually we do in the homes and how we believe it makes a difference for the patients that we serve. So our first slide is really talking about why does this make sense to us as an organization, specifically why does it make sense here in Atlanta, and I know demographics vary from community to community, so this slide shows how our population in Atlanta is growing, and as you can see, it's a significant increase, and I would say it is going to vary, but we all agree that folks are aging in place, our aging population is growing, so even though this is an Atlanta-focused slide, I think this represents most communities in this country. So our second slide talks about a shortage of primary care physicians, and really this is an important piece because primary care is the entree point for all of us, and where we receive our primary care, whether it's through a family practitioner or an internal med physician. It's important to note that this is a problem that healthcare is experiencing, and also that geriatric primary care in particular is really an unmet need in our medical education system. and an area that I think our seniors really suffer because they are not being seen by primary care physicians and internal medicine physicians who really have an expertise and a specialty in treating geriatric patients. Okay, so the next slide is talking about the challenges and why we think it makes sense for visiting nurse health systems to start a house call practice from we have been in home health for 60-plus years, hospice, and then long-term care, and we work very closely with our hospital partners in healthcare, the healthcare system, and we definitely see that it's focused on acute and episodic care, and in that a lot of unmet needs have been identified through some of the challenges we face in our other service delivery. So meeting the specific needs of frail elderly is a very different population than treating someone who's 30, someone who's 40, and that's a specific need and a challenge that we're trying to address through our house call program. Also, as individuals age, their medical needs become more complicated, multiple and often chronic conditions, and I would venture to guess many of us have had the experience of taking care of a loved one as a caregiver, and we really understand this on a personal level. It really is a part of our fragmentation of healthcare. So with house call, we're focusing on really a comprehensive primary care setting in people's homes and looking at those chronic conditions and the opportunity to see really how people live in their homes is an important piece of our delivery model. Also, the average primary care physician spends less than 7 minutes with a senior with multiple chronic conditions. This was a statistic that came out of the Journal of Medicine and a study that came showing that our seniors, from a primary care perspective, with the most medical chronic conditions, are seen the least amount of time by our primary care system. Also, physical, mental, and economic factors make traveling to a doctor's office difficult and sometimes impossible. When we're all independent and relatively healthy, it's hard enough to get to the physician, but when someone is sick with chronic conditions, some aging issues perhaps related to being able to see or other sort of aging issues, just simply getting in the car and making it to the physician is a barrier to care. Patients remain in their homes until an emergency occurs, and I think that's just human nature, that people will stay where they are until a crisis. So the result of that is our healthcare system, particularly our hospital and ER system, end up taking the brunt of where the primary care is lacking. So we believe this challenge we're addressing through our house call model. Also the crisis management, and I think from a healthcare perspective, so much of healthcare in acute care settings is really crisis management. It's not the long-term planning and the preparing that goes along with a good primary care model. And lastly, the challenges, it's necessary to change activities of daily living that they're not funded currently. So as our aging population continues to age and the frailty needs are addressed, it's not something that our healthcare system really addresses in the acute episodic way. So if someone is having difficulty making a meal or bathing themselves, those are things that impact compliance. Those are things that impact an ability for them to be able to see their primary care physician. So these are what we identify as our challenges as an organization. And so our answer has been the house call program, and it's a home-based primary care. We focused on Atlanta's low mobility elderly population with chronic illnesses. We believe it complements health care services provided by a visiting nurse for more than 60 years. It also allows our medical team to identify and treat most illnesses in the home, and also improves patient quality of life, reverses the dysfunctional cycle of care delivery, and decreases the cost of care. So the ideal candidate, Edward, I think you were going to take this part.
Sure. Thanks, Dorothy. This is Edward Espinosa. Thank you for to everyone for helping and organize this. Thank you, Patty and Mary and Lisa. This is a program that I'm very excited about, and we all are at Visiting Nurse. What I would like to do in the next 3 or 4 slides is just a picture of what this program is about, and specifically what we do to positively impact the lives of these frail and aging seniors. I'm not controlling the slides, but if someone could advance the slides to the next 2 slides. Where
it's on the delivery model, and we just passed the ideal candidate.
Oh, so I must have lost my connection. Okay, so let me go for my hard copy. What this slide, the ideal candidate for household, this is basically the type of patient or the criteria that we're using for our patients. Most of our patients, actually all of our patients are enrolled in Medicare. Most of them have 2 or more chronic conditions, and they're basically disabled. These are patients that have a taxing effort in ambulation, just limited walking ability, limited ability to get out of bed, and so there is a barrier to get to their primary care doctor. They tend to not see their primary care doctor frequently because of this. The frequencies that we've seen for the patients that we've enrolled are approximately 1 visit or less a year. And obviously that's of concern, because what in fact ends up happening with their care is they're using the emergency room for their primary care and subsequently are having more hospitalization. And the point to highlight is that while emergency room visits and hospitalizations become more necessary as we age, what we're trying to focus on are the unnecessary or preventable emergency room visits and hospitalization. So these are the candidates. Most of them geographically are within I-285, and by default they don't have an existing primary care physician, or they're not active with any practice. If you can go to the next slide, please. Obviously, these visits are made to the home. They're either made by a nurse practitioner or a physician. Our delivery model presently is more of a nurse practitioner driven practice, where clinicians are going out and seeing the patient between 6 and 12 visits per year. So that's, on average, we're seeing them we're seeing our patients every 2 months approximately. Our practice is what you would typically expect in a primary care practice. If you're going to see your family practitioner or you're going to see your internist, you will get routine evaluation, such as physical exams, screening. We do blood work in the home. We do imaging. We have mobile x-rays and ultrasounds. We have portable electrocardiograms that we do at the bedside. We use electronic medical records, so we are basically a paperless office. And what we've kind of coined as this modern-day black bag, where we can have mobile diagnostic tools available to us to appropriately diagnose and treat our patients. And the goal, and where we are right now, is being able to treat patients equivalently as if they were in a doctor's office. And so, in fact, we become their primary care physicians by doing this. If you can skip to the next slide, please. Our typical patients, we see acute and chronically ill patients. From the acute side, we take care of pneumonia, asthma exacerbations, COPD exacerbations. We treat urinary tract infections, and much of it is diagnostic in that we can go to the patient's home, do vital signs, check blood work, check urine studies. and if need be, we can give them at the bed IV antibiotics, IV fluids, electrolyte supplementation if they need to. So much of what we're delivering is primary care that in certain situations, in certain practices, isn't necessarily delivered at that level. So some of the services that we provide are above and beyond what you would typically get at a primary care office. We also manage chronic illnesses, heart failure, atrial fibrillation. We monitor blood thinning levels, and along with this, we coordinate care and communicate with the patient specialist. So we're in constant communication with patients' cardiologists and their endocrinologists, their pulmonologists, and really providing timely care to them and being the eyes and ears for their specialists in order to make clinical changes that could impact how their chronic condition is managed and whether they need to be hospitalized more frequently for this. Next slide. And again, what I mentioned before, some of the modalities that we have available, including phlebotomy and IV access and labs and medications as needed. To give you a picture, I'd like to just give you an idea of a patient current patient that we have, and how we can positively impact their lives by the care we deliver. We have an elderly gentleman who has Alzheimer's dementia. He's in his 80s, and he has had frequent hospitalizations due to recurrent pneumonia. He tends to have aspiration, and so the fluid is going down the wrong tube and ending up in his lungs. And obviously this is causing infection, but it's happening so frequently that he is routinely transported to the emergency room and often hospitalized for these upper respiratory tract infections. When we started seeing him approximately a year ago, he had actually almost a year and a half ago, he had almost 3 to 4 hospitalizations per month. So very frequent hospitalizations. We started seeing him, caring for him, putting all the pieces together, and found out that yes, he's aspirating. We had the speech therapist come out and evaluate him, and what we found was as soon as he had these signs of aspiration and cough, we could treat him with IV antibiotics and/or IV fluids, prevent this pneumonia, and prevent an emergency room visit and a hospitalization. Now, while we haven't solved the problem with the aspiration, we've solved the issues with the frequent hospitalizations, and his quality of life has improved, as has the quality of life for his family members who are most concerned about him. So there's definitely a positive impact that we can have on these people's lives as far as their overall health and their quality of life. Dorothy, I think that's kind of in a nutshell what I wanted to cover. If you want to take the next slide.
Okay. Thanks, Dr. Espinoza. So a big part of putting the pieces together, as Dr. Espinoza was referencing, is the social service piece, the caregiver, the family, the stress that the caregivers are under, and the patients, and really looking at what are those other pieces that really impact somebody's quality of life and the overall experience of their health care and the family. So social service is a part of this, of our model. We currently do not have a social worker who's dedicated on the house call side. However, through long-term care at home, there's a lot of coordination, as well as on the home health and hospice side, where we have collectively over 90 social workers that are available and can help address the issues that are not addressable by way of medicine or a skilled intervention, but are very much involved in a patient's experience and their ability to remain safely at home with quality. We also look at, just like a primary care practice, where the ancillary services, what are the additional services that this patient and family may need in order to wrap around and keep them safe at home, and that's often social services, but can include home health, wound care, palliative services, some of which visiting nurse currently provides. But it is a picture of how can we help stabilize the patient at home, which is a part of our model. So I'm happy to announce that a part of this, our house call, when we launched it back in late 2010, there had been an ongoing bill around independence at home, and what that meant or means is that there is a recognition that home or house call services really is an unfunded, I mean it's funded but not at the degree at which it costs. And there had been an act trying to get some awareness within the healthcare system that it is important to provide services in the home. So independence at home was incorporated into the healthcare reform and as a demonstration. Visiting nurse applied back in February, and we received news yesterday that we had been awarded a place at the table with this demonstration. And I want to talk for a minute about what we'll be doing, because we will be demonstrating with other providers around the country, and they did limit it, so it's not like it's a huge demonstration. There'll be 10,000 patient participants, so to be able to be a part of this is really an exciting thing for our organization. But we'll be looking at just the things Dr. Espinoza was talking about. How can we identify and really target those preventable hospitalizations and emergency room visits? So Medicare has recognized the value of home-based primary care, but at this point, they really do not have a payment model that would support many people doing house call. So the need for foundations and funders to recognize that from a business perspective, there's a lot of reasons why people are not doing this service because the business model just does not support this making sense. So through this demonstration, it's a 3-year demonstration, and we will be looking at some very clear metrics, and that will be on, I think, our next, I think I missed the slide. Yeah. Okay. So I'm going to go back and talk for a minute about the performance metrics, because we have identified our performance metrics as the key metrics for independence at home. So these are the things that we are looking at as our places to evaluate and understand how we're making an impact. So we survey our patients at intake after 90 days of care and 6 months through patient satisfaction surveys. I think it's very important to listen to patients and caregivers around their experience of our service and what was happening before their admission into our service. We track hospital readmissions, and to Dr. Espinoza's sort of vignette, that's an important piece we want to understand. How are we preventing unnecessary hospitalizations and emergency room visits? We also sometimes refer people to emergency room and hospitalization when it's appropriate, when there's really nothing from a house call perspective that we can intervene on. But that's something we track and we want to understand. And then we also look at referrals to other services. How are we helping support the patient and the family at home through other wraparound services that would be, lower cost, not only to our healthcare delivery system, but really what patients want. They want to stay at home. So I'm going to forward to the next slide and talk. I was talking about independence at home. So we are now a participant in this demonstration. We'll be measured based on how we can demonstrate cost savings to the overall healthcare system. We'll be providing monthly reports to CMS about our performance. They also will have an independent auditor that will be pulling claims data to review their acuity patterns and how frequently, cost analysis. And from those reports and also the cost analysis, anyone in this demonstration will be eligible for the shared cost savings. So that's available to any participant. It will not be available to us until 18 months into the demonstration because of the way the claims data runs. But this is a great opportunity for us to demonstrate the savings to the whole system when we take care of folks at home. Our patients, we served over 150 patients in 2011. 48% is Medicaid, and I think that's an important point to talk about when we address barriers to health care, and money and is a part of that story for people. So if they're on limited resources, then they have less access to services and they have less resources to get what they need. So 48% of our patients are on Medicaid. 97% of our patients are 60 or over. 70% are female. 53 are Caucasian. 40% African American. And also, even though 48% are Medicaid, we track over 80% are considered poor or underinsured. And the last point, which is, I think, a very critical part to understand, which is 30%, and Dr. Espinoza and I were talking yesterday, we think this is underreported. Suffer from Alzheimer's or other forms of dementia, which greatly impact their ability to go to the doctor, their experience and how they're able to care for themselves, and just overall caregiver burden. So finally, we want to share some of our results from our most recent patient satisfaction survey and what we consider our early successes. As you can see, we have sort of a before admission to house call, how many of our patients had been admitted to the hospital, and this is, I want to add, a self-report. So this is self-report from the patient or the caregiver, and you can see that we had a high percentage of folks who were admitted 1 to 2 times within the last 12 months prior to admission in house call, 47%. 6 months on house call, you can see 89% had not had a hospitalization. And I think that's exactly what this program is about. And our next slide talks about how many times have you been in the emergency room. So we have a distinction between hospitalization and emergency room utilization. I think the CMS has a distinction, so really talks about how well we can manage someone at home. So 12 months prior to admission, our patients reported that 42% had been seen in the emergency room, 5% had been seen 3 times or more, and 6 months on house calls, 85% of our patients reported they had not been to the emergency room. And Dr. Espinoza, do you have a story that might be that speaks to this, particularly around how a patient interfaces with our house call primary care, how we help keep folks safely at home? I'm thinking about a sort of patient education or even a caregiver, just some of those early warning signs because we're in the home that would speak to how.
Sure. You know, one of the things, there's much of these preventable emergency room visits are driven by the management of chronic medical conditions, not necessarily acute medical conditions. So if somebody becomes sick where they need to be seen in the emergency room because of chest pain or stroke symptoms or even a bilateral pneumonia on both sides of the lung, you know, we can't really do that much, and it's not an emergency room visit that needs to be prevented. But where we see opportunity is with the management of chronic conditions. And I'll give you an example. At one of the hospitals where I'm on staff, we have frequent patients that are frequently seen in the emergency room or hospitalized due to worsening of their congestive heart failure. And really when it comes down to it, it's about fluid management. And it's about recognizing when the person is fluid overloaded or dry. And neither one of them is good for a patient with heart failure. If they become too dry, their kidneys don't do well. If they become too wet, then they have problems breathing, and there's a lot of strain on the heart. So managing fluid status is key in these patients. And what happens is the fluid status becomes so out of control because they haven't seen their primary care physician and no one's really monitoring what's going on, that they have an emergency room visit usually every 7 to 10 days, and a hospitalization about 50% of those emergency room encounters. And it's something very simple as far as managing it. It involves, checking their weight and checking to see how their legs are doing, if they're swollen, and really just making small adjustments to their medications, their diuretic medications, for instance, their Lasix. It's something where we can go out and catch these things early and prevent a visit to the emergency room just simply by saying, they're a little bit fluid overload, let's increase their Lasix, their regular dose of Lasix, or we can even give them Lasix IV if we think they need to be treated a little bit sooner and more aggressively. So these are areas as far as managing chronic diseases and keeping the patient tuned up, if you will, that will prevent these unnecessary emergency room visits and the more costly hospitalization associated with that.
Thanks, Dr. Espinoza.
Mm-hmm.
Our next slide talks about, and to me I think this really speaks to what's going on for patients and caregivers more than anything, because how many times have our patients in our current house call practice seen a primary care physician or nurse practitioner? Honestly, I was a little surprised myself when I read this. So 12 months prior to admission to house call, 74% of our patients had not seen a physician in the last 12 months. And I think that speaks to a lot of the barriers into people's experience, their sense of helplessness, family stress, caregiver stress. I think dementia and Alzheimer's is a very big component because of the confusion that goes on when you try to take a family member out of their familiar environment when you take them to the physician. And so 26% of our patients prior to admission to house call had seen a primary care physician or a nurse practitioner 1 to 3 times. And since being on service, you can see the increased utilization of the primary care in the home. But I also want to add the ability for Dr. Espinoza and our nurse practitioners to experience what's happening for the patient in the home and then be able to really assess their needs and utilize services across our organization and out and within our community. So 62% of our patients had been seen 5 times or more within our service within the first 6 months. 1 to 4 times, 38% had been seen 1 to 4 times. That's such a dramatic increase of care. And again, they come, our patients are admitted with multiple chronic conditions, to Dr. Espinoza's point. So I think we're really having an impact on a population that had not been receiving services, and when they did receive services, it was in the emergency room and in a hospital setting. Dr. Espinoza, anything you want to add from your perspective on sort of the increased utilization and what you're hearing when you care for patients?
Well, one thing that I wanted to add that's an important component, and I think it helps with compliance and keeping people as healthy as possible. As a physician, going out to someone's home and engaging them in their own comfortable setting of their home, whether you're talking just to the patient or to their family, crossing that barrier from being in an office to going into a setting where it's more personal and you're in their home and you're seeing what their environment is about and what barriers that they have and how you can help, not only has impact from a clinical standpoint, but also from a trust standpoint and from a sense that this is the medical team taking care of me or my family member, and there's more of a sense of trust and confidence and a personal sense. So there's clearly a benefit that is there that maybe is more of an untangible, unmeasurable benefit by going to people's homes And I think that reflects so much in these metrics that we're seeing. It's something that is you just feel as soon as you're going into someone's home, you cross into their space, and you're more part. There's more of an intimate partnership where you're really working to make their loved one better or the patient better.
Excuse me, this is Patty, and I want to interrupt for clarification. I got a chat message asking, just for clarification, these dramatic improvements on these three different slides using the pie charts, that's for the people that are only on house call, correct?
Correct.
Oh, wow.
This is a patient and caregiver self-report. So these results come from a patient satisfaction survey that was just completed a month ago.
Okay.
Patty, hi, this is Tina. May I ask a follow-up question if that doesn't interrupt the flow?
No, not at all. Please, Tina.
Actually, I had a question with regard to this current slide in terms of the 12 months pre-admission to house calls and then the 6 months on the house call program. I wondered, with this report of the number of visits with a primary care physician or nurse practitioner, does that represent just the house calls professionals, or is that a combination of the primary care physician, which might be in the community, as well as the care that the patient would be having in the home?
Let me just make sure I understand your question. You're asking about on the 6-month results, if that only includes house call, or are you asking about the 12-month prior, if that includes only house call or office-based primary care?
It was the former. So my question is, these 1 to 4 visits that 38% of the patients are self-reporting, is that just for the interaction with the house call program?
Yes. Yes. Yes.
What about any visits they may be doing with their primary care physician? Would that be captured in your questionnaire as well?
Well, we are their primary care. So, and Dr. Espinoza, you may want to talk to this from how the practice,
Sure.
developed.
So the way the practice is set up is when we enroll a patient into the practice, we become their medical home and their primary care physician, their PCP. We are caring for them in all areas. We pull all their existing records from their previous primary care physician. The understanding is this patient is not going to see their primary care physician or does not have a primary care physician because they don't have the ability, they have limited ambulation or whatever their barrier may be. And so we in turn become their primary care practice. Now, they may still have visits with their specialist, but usually those are very infrequent visits. And so, really to answer your question, yes, these are the house call visits where we see the patient in their home and we are serving as their primary care physician.
Great. Thank you so much for clarifying that, because I'm not certain I gathered that from the prior slides, and I'm so glad you used the term the patient-centered medical home as well, because that really clarifies this even more for me. So thank you so much.
Sure, my pleasure.
Mm-hmm. Good. Dr. Espinoza, would you speak to one of our more complicated patients, not just medically, but psychosocially, family issues, just what's involved to be someone's medical home and all the pieces that we're holding?
Sure.
And how it may even be different in someone's home?
Sure. And I guess let me point out by giving you this vignette that it still surprises me when I go to see people's homes. I may see someone in downtown Atlanta and they are maybe half a mile away from Crawford Long Hospital or Atlanta Medical Center, and yet they have not seen a primary care physician in over a year with multiple chronic medical problems. And some of it is complicated by their financial resources. some of it is complicated by psychosocial issues where while there are barriers there, those barriers are more difficult to overcome because these patients may have dementia, they may have psychiatric issues, and they frankly don't have the support system that's available. And what's happened is in downtown Atlanta, these patients have fallen through the cracks. And so we're coming in and really picking up the pieces and evaluating them from a big picture standpoint, from a primary care standpoint, and frequently they need specialty follow-ups from whether it's cardiac or they're in renal failure and they need to be evaluated by a nephrologist. So many aspects of it that it's literally it's almost as if you're starting from the bottom floor and working yourself up to bring this person into an adequate state of health. And a lot of it just has to do with their access to care. And it, what I explain to people, it's not that there's not enough doctors, or although we are in somewhat of a primary care physician shortage, but access in a major metropolitan area, there's hospitals, there's doctors, they just can't get there. And the reason they can't can be for physical barriers, psychosocial, financial, whatever those barriers are, they exist. And there are patients that will benefit so much from a program like this because we can identify them and plug them into the system where they've fallen out of the system. We plug them back in, and we become their medical home. And we pull all their old records, and I just saw a patient yesterday where, what kind of care are they receiving in their home? Well, this patient is having worsening renal function and is going to need to see a nephrologist and may potentially need hemodialysis. Were we not to intervene and get involved, nothing would be done. And frequently, when you go into renal failure, you don't know what has happened until it's too late. So, I don't know if that makes sense. That's a little bit of me rambling, but that's what I'm seeing, and that's where I see this great opportunity for us to go to the patient's home and kind of break through those barriers and plug these people back into the system.
Thank you, Dr. Espinoza. So our last slide is talking about program funding, and I just want to say again why this makes sense for a visiting nurse to be in the business of house call. All our services, with the exception of our inpatient hospice facility, is delivered in the home. So we have a skilled group of clinicians and over 500 clinicians who are in people's homes in a variety of services, but they cross over that threshold into people's homes and really understand how people are living. And I think that provides organizationally an opportunity for us to understand and serve the needs differently and better here in Atlanta. And it was a lot of discussion in preparation, but we really believed there was an unmet need, and it was our delivery team. It was the clinical team saying, this is really an unmet need. And it was we spent a year talking about it, doing some strategic planning, and then fundraising for it. And so the program funding, this slide speaks to where we were in 2011. 2010, Jesse Parker Williams Foundation was our first foundation that supported our program just to get us started and to believe in this model. You can see the evolution in the last 2 years of where we started from patient revenue in 2011. 35% of our budget was generated from patient revenue. 65% was off of grants. And this year, where our projections based on our budgeting process is 67% of our budget will be generated off of patient revenue. And these projections don't include independents at home. Those revenue potential will not be realized until 2014, probably in late 2014. So 67% of our patient revenue, of our revenue will come from services we deliver in the home, and 33% come from grants and foundations. And you can see some of our supporting foundations in Jesse Parker Williams Foundation, J.B. Fuqua Foundation, Georgia Healthcare Foundation, and Mary Allen Lindsay Brand Foundation.
When you say patient revenue, are you talking Medicare, Medicaid, that sort of thing?
We're talking Medicare.
Medicare.
We're talking Medicare. We're also talking, any form of Medicare, including HMOs.
Okay.
So, questions?
Yeah, it is 3:52, so we do have a few minutes. If others have questions to ask Dorothy or Dr. Espinoza.
Patty, this is Tina. I had another question. I wondered if you could talk a little bit about what the duration of the patient visit in the home might be and how that might compare to an office visit, especially as these patients are so complex and have so many chronic illnesses.
Dr. Espinoza, would you answer that?
Sure. Let me give you a little bit of the picture. We know a little bit about the patient before we go to see them initially because we've pulled the prior medical history. We go in and they have filled out some forms prior to the visit. But we go and we do and I'm just talking about an initial visit, but a thorough physical exam. We do vital signs. We do a baseline electrocardiogram, and we do some blood work to get some baseline numbers. We screen for vaccinations, see where they may be in need of a pneumonia vaccine or flu vaccine, whatever it is that they're deficient in. And then there's some time where we're doing some counseling with the patient and the family and looking at their needs from a social aspect and from whether it's durable medical equipment or whatever needs they might have, physical therapy, whatever ancillary needs they might have. Then there's a point of documentation where we're entering the information into the electronic medical record. So all that, in a nutshell, the typical visit is lasting somewhere between around 40 to 45 minutes for the visit. Follow-up visits are usually between 20 and 30 minutes. And that's pretty much the timeline. So we spend more time with the patients than you would have in a traditional practice. And a lot of that has to do because there's one person going out. So the nurse practitioner or the physician is going out. They're doing their own vital signs. They're doing the physical exam. They're doing their own electrocardiogram and their own blood work right there at the bedside. If they have to administer IV fluids or IV antibiotics, that lengthens the visit. But again, it's all being done by a single clinician.
Great. Thank you so much for explaining just the intensity of effort that goes into that home visit.
Yeah.
Sure.
I think Paulette's got some related questions.
Hi, this is Paulette Parker with the Williamsburg Community Health Foundation in Williamsburg, Virginia. And what is the minimal and typical credential levels for the visiting nurses, and how much time do they spend in transit, and what's the typical caseload?
Dr. Espinoza, I'll give a shot at that. So to your first question, and some of this is going to be specific to each state, but in Georgia, we utilize nurse practitioners. Dr. Espinoza is the medical director, so the requirements in our model is an advanced practice nurse. Mm-hmm. And again, each state has some different variations to sort of licensure and regulation related to how a nurse practitioner or an advanced practice nurse can work in conjunction with a physician or a collaborating physician. To your question around caseload, there's ideal and there's what's actual. And to me, this is what is so critical in how effectively you can operate and just ramp up time, because you cannot, we cover a wide distance inside 285, and for those of you not in Atlanta, it's not a lot of geography, but when you factor in traffic, it can be an hour between the top end of our service area to the south end. So we have to factor that in a new program, and we have. So our average caseload, what that has looked like per day has varied greatly because of geography. And that, as we have grown and have had more, up to 150 patients, we can schedule smarter, really do those routine visits in clusters, and increase our ability to see, 6 to 7 patients a day. That's our ideal. That's what we hope for when we have enough enough patients that we can, schedule this area of Atlanta, this zip code. But that is definitely the high end. And to your question of how much time spent in transit, I think that varies greatly depending on, the schedule. And I will say from an operational perspective, it's very important that the scheduling piece is done well and thought through, because that is how you can ensure that the clinical team is spending the most time with patients in the home. And that really is something from visiting nurses' perspective that we manage from the office and triage some of that. Now, Dr. Espinoza, you may have some other comments, particularly on the transit.
Well, and I guess let me add to this that when we set this program up, and as we have continued to develop the program, we are not really working in a vacuum. We are touching base and having discussions with other house call programs in different parts of the U.S. We've talked to people in Washington, D.C., and in California, and we went and visited a large house call program in Chicago, Illinois, and really trying to gather from them the best practices as we grow, including geographic scheduling and trying to make the most efficiency, having to reach the most efficiencies with our visits. And so while we're still learning the process, we're starting to see more and more the nuances that are there that really exist throughout most of the house call programs that we've seen throughout the country. So, and we're also part of the specialty group organization for house calls. So there's a lot of communication that takes place as far as what is going on with transit times and when is the best time to do labs and who should be, should this be something that's done separately. We now are starting to use a company here in Atlanta that does mobile imaging for us, echocardiograms if we need them, x-rays and ultrasound of the abdomen, for instance, where we had initially thought about, well, let's buy an ultrasound machine and use it, for our visits. So we're pulling these best practices ideas from other existing practices that have been around for some time and trying to borrow some of their successes, if you will.
Thank you.
Are you joining this 4 o'clock call with CMS? With all the bigwigs?
Yes.
Dorothy?
Yes, any other questions? We're right at 4.
Yeah.
Our contact information, if you'd like to follow up with either myself or Dr. Espinoza, is on the slide, and our website, which you can go to and read more information about our house call program and our organization in general. We appreciate the opportunity to share something we've been very excited about.
Thank you. Thank you both, Dorothy and Dr. Espinoza, and thank you, Mary, for coming up with the idea for this program. I have found it exciting and very informative. Thank you very much. Now, don't forget to fill out the webinar survey as you leave the Ready Talk site, and don't forget our webinar next month. It's going to be on a slightly different track. It's going to be about advocacy. The title is Georgia Women's Policy Institute, Training a New Generation to Advocate for Older Women. It's sponsored by the Healthcare Georgia Foundation and presented by Lisa Medlin, Program Officer at the Healthcare Georgia Foundation, and Stephanie Davis, Executive Director of Georgia Women for a Change. So I hope to be talking with all of you next month. And thank you so much for joining us today.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you. Please stand by.